So for tonight, again, we're going to go over diagnosis and medication. I like to start out, since this is a free class, I like to just start out with free resources. Um, Anytime I get a chance to, share resources as a social worker, that's just what we are here to do. So my main thing, of course, is to help you, whether you want to engage with any more classes with me or not. So, these are some free resources. And I normally I went over these the first free class in the if you attended the exam basics. I included this as well, but just in case you weren't there, wanted to give you this information so that you know you can always have this information just when you're trying to figure out what to review or things on YouTube to do. You have this information. Also, in the email that I sent out, I also had some additional YouTubes that were specific to what we're talking about tonight. So some of the areas like personality disorders you'll find in there. Um, and so you have those resources as well, because sometimes you need something else, right? Um, so a lot of questions that I get is, should I buy the DSM right now? We're on the 5TR. Should I buy the DSM 5TR? And so my answer to that is that I feel like all social workers should have some form of it, whether it's the full thing. If you're a clinical social worker, you probably already have one. But um, even if you have a briefer version or like a desk copy version, where it's a little bit of a almost like a shorthand, I definitely recommend that. And then I have a link in here for a quick study guide as well. That's more for the purposes of the exam, but also could be beneficial for that, like quicker. I just need to look at, what this disorder is about. So for diagnoses and medication, it's going to look different on different exams. What I would say is that none of the exams are all diagnoses, right? For me, studying for the master's exam and studying for my advanced generalist exam, I studied a lot of diagnoses because I mean, that just seems like the epitome of social work. And I think it's one of the areas that people say is their weakest and they need a lot of help in it. But the truth is that for the master's level, it's very few diagnoses, questions. For the clinical level, I would say there's going to be definitely diagnoses, questions. However, it's not all. So I think that what I hear a lot from my clinical test takers is that they expected more of disorder questions. What I would say though is that sometimes it won't be that it's asking you to diagnose, but it will be that it's asking you how to treat based upon their symptomology, right? So if you have a client that is, for example, a client that has schizophrenia, right? There are certain techniques that may not work well based upon what the kind of key features are. So, for example, schizophrenia has a lot about expression, right? So, disorganized speech, um, negative thinking, flat affect. So you have all these things that are about expression. So maybe journaling and awareness might not be the focus if I'm working with a client that has schizophrenia, right? So those types of things, right? Because if they have disorganized speech, trying to get them to express, that might not be a great technique or assignment for working with this particular population. So things like that, right? What are things that are specific to the disorder that you would want to know? So, for example, we all know that borderline personality disorder and DBT kind of go together. So things like that, like taking it a step further in terms of the clinical exam, yes, these are the mental health disorders that are in the DSM-5, but what does this look like in terms of what you're going to do with that information? So I wanted to make sure that you knew that not only will you see what is it, right? But also you may see what should be your interaction with this client based upon this diagnosis, right? So making sure of that. Another example would be with borderline personality disorder, we know that having strong boundaries can be very important. So for another client, my boundaries with hugging might be a little looser, but with a borderline client, it might be a little stricter, right? Because therapeutically, that kind of really addresses kind of what they're going through in terms of the disorder. So those are things that I wanted to kind of point out. Um, Obviously, you could study the DSM-5 and just open it up and study it. That's what I did when I was studying. I think there are so many things that you can do other than that. Um, but if that's something that you're just more comfortable with, you can absolutely do that. Like I said, there's a quick study guide that might be a little bit easier. I also have slides that break it down, so that's a little bit easier, so you don't have to just like open up the DSM-5. But there can be some benefits to doing that, especially if you are um, not familiar, right? Or if these are not things that you're constantly looking at, right? I was in child welfare, and so um, although I had knowledge of these things, it wasn't necessarily things that was encountering uh where I was treating them. And so I would see them, but maybe not, I wasn't treating it. I wasn't a therapist at the time. So um some of these things I really didn't need to study because I was like, what is this? Right? I still am like, what is this? And then I put some common medications. Obviously, you could see you could see none, you could see different ones. I will say that there are brand names and generic names on there. And then I also wanted to make sure that you didn't forget about substance use, right? That substance use and medication assisted treatment. Um, could also be on the exam. I'm not saying that there's a high probability, but I don't want you to forget about those different types of drugs as well, because they're also could be on the exam. And then I just put in here about the paradoxical effects because that's something that had came up as a hot topic, about the fact that ADHD medications um, are stimulants, or you can prescribe a stimulant for those that have ADHD, and it has a paradoxical effect, meaning that even though it's a stimulant, it actually has a calming effect or the opposite effect if you have ADHD. And that's the paradoxical effect. Um, and something that is not something we talk about a lot, so I just wanted to make sure you knew about it just in case you do see it on the exam. With diagnosis questions, you want to highlight all of the symptoms present in the question. So, not all scenarios are going to be textbook in that, like, for example, with major depressive disorder, you need to have five, right? So, it might not list all five. So, it might not be an exact of eligibility requirement. That's normally why it says what is the most likely diagnosis. But it will give you those key symptoms. So I always say time frame is really important for you to know. Age of onset could also be important if it's a like a child disorder versus one that only, or not, I won't say only, but typically presents later in life, like a young adult. Typically schizophrenia is like a uh adult presentation versus a child presentation. So sometimes that's important to know. Um, and then you really want to make sure that you know the main features of the disorder, and we'll talk about how you find that in the criteria. And knowing that symptoms do overlap, like irritability. I don't know how many disorders have irritability in it, but it's a lot of them. So you can't just be like, well, it says irritability, therefore it's depression, right? Because it could also be oppositional defiant disorder. It could also be anxiety. It could also be, right? So the list goes on and on. So we don't want to say uh just look for one word unless we know it's the main feature. So master's level is more about symptom recognition. Clinical level, also you want to make sure that you're adding into your study differential diagnosis. And differential diagnosis meaning, hey, this is the symptom. What are the different diagnoses that could fit this? And really, what is the difference between them and what distinguishes them? So taking it a step further, when you look in the DSM-5, it has a section about differential diagnosis, right? Making sure to give you diagnosis to rule out before you're like, okay, it's definitely this. All right, let's go. So I put the link in the chat. I'm gonna put it in there just one more time, just in case you just joined. And how this is going to work is I'm going to pause. You're going to go on the chat. Go on the poll, answer the question. It's only one link for all the questions, but it's going to display one at a time. And then we'll review the answer. One thing about diagnosis and medication, it seems to go a little quicker because it is kind of it's not a lot of reasoning happening here because it's more definition based and based on criteria, or based on the medication. So, um, I do have several questions because we'll probably get through them quicker than we would like a direct practice question. All right. So we were a little bit all over the place, but I wanted to definitely, with this question, I also wanted to kind of talk about what the changes are with the TR versus just the regular DSM-5. I know that there's some changes going to be happening in 2026 in terms of the outline of the exams. And so, I always get the question, is the TR on there? And so I'm not exactly sure when it'll be like an official change, like, yes, please do the TR. So I want to make sure you know the changes, um, just in case. So this is an accept question. So that means that your process of elimination is going to be a little different. You're going to eliminate what is correct. So there is a new diagnosis called prolonged grief disorder. So you want to make sure you know what that is and kind of review that if you haven't. There is an addition of symptom severity scale for anxiety disorders. There was a change in terminology from gender identity disorder to gender dysphoria. So making sure you understand that. And then D is not correct. So in the DSM-5, autism spectrum disorder was reclassified to encompass previous separate categories, including Asperger's syndrome and pervasive developmental disorder under a single umbrella term. But this change was already present in the DSM-5. So it's not something that happened this cycle, it happened a previous cycle. So it's true that it did happen, it just didn't happen with the DSM-5 TR specifically. I also included and I'm gonna put the slides in just one more time, just in case anybody missed it the first time. There is a video on the changes, and then this is the quick study I was talking about. It's on Amazon. It's typically like very reasonable, like $7 or $8 or something. It's laminated and it's like a nice tool to keep readily available, especially if that's something you want to kind of be like, what is that? What are this, quick. It's not going to have everything on it, but it is something just as a quick kind of what is it type of thing. Okay, let's go to 2. All right. It looked like we were trying to. Oh, the poll has 4 options. It sure does. And I bet the answers have 4 options. Sorry about that. I'm only human. Sometimes but the answer is still right, just to let you know. You just had an extra choice. Answer is major depressive disorder. So this is Prozac is the brand name. And that is going to be fall into our commonly prescribed for depression. Now, when it comes to medication, it can be sometimes confusing. So I do want to speak a little bit. We're going to talk about the medications a little later too. But in terms of let me see. Oh, anxiety. In terms of anxiety medication, you have anxiety medications, right? Um, but anxiety medications have some side effects. They can be addictive, and they can also they're fast acting, so they're good, but they can also be addictive. So a lot of times, doctors and psychiatrists will prescribe depression medication for anxiety, but you want to go with the major, um, or the common use of that prescription. Now, if it talks about kind of the negative side effects of using anxiety medication, like if it talks about the person has anxiety, but they want to be on medication, like a long-term medication, then you wouldn't use anxiety meds, the traditional ones, because they can be addictive. And the answer would be a depressive medication. So let me just repeat it. Anxiety medications are fast acting, but they are addictive. So typically you can match them. If they have generalized anxiety disorder, you would match it with an anxiety medication. But if it talks about you don't want to have like the negative side effects of anxiety meds, or if it talks about you're treating anxiety, but you want to treat it with a medication you can place the client on long term, then you'll know that you don't want to do a traditional anxiety medication. You would select a depression medication, because those medications are ones that you don't have to worry about, with the side effects of the ones of anxiety. And we'll go over that again when we talk about medication a little bit later. The TR is the revision. Um, I'm sure it actually stands for something, but we had the DSM-5. It's just another version of the DSM-5 but they did some revisions. But they're not major revisions to the point where they would go to like DSM-6. But I'm sure a DSM-6 is in the works. Okay, let's go to 3. Okay, that was 45 seconds, just to let you know. But I'm gonna give you a few more seconds. I kind of gave this answer away earlier when we were doing our little summary. What best explains this behavior change? We talked about ADHD, and a stimulant. The parent tells the social worker it's night and day. He sits through class now, doesn't interrupt as much, and can focus on his homework. The teacher reports improved attention and reduced fidgeting. So the fact that they talked about the ADHD and the stimulant, that's going to connect to our paradoxical effect that we talked about, how that in when people have ADHD, it really is a calming effect. Um, all right, let's do 4. All right, let's see what it is. Okay, it looks good. Answers look good. We have excessive worry. Um, Difficulty sleeping, muscle tension, restlessness. Um, that's important, but I would say the 6 months, the excessive worry, and it's difficult to control and interferes with daily activities. We know that is our kind of textbook when it comes to disorders, is that we typically will see that it is impacting social or occupational functioning. So the answer is C, generalized anxiety disorder, because it is characterized by excessive worry. That's really what we wanted to look for at least 6 months. And then here's a slide just giving you a little bit more information. It has to have three or more of following symptoms. Um, and we saw some of these symptoms in the scenario as well. We know that if we go back, we know that difficulty sleeping could also be with depression. Um, but we don't see any of the other depressive symptoms, and so that's why it's not A. Okay, I'm gonna keep moving. By definition, tell me in the chat, bipolar 1 or bipolar 2, which one is more severe? Yes, bipolar 1 because it has that manic part to it. So the answer is C. Bipolar 1 involves at least one manic episode, while bipolar 2 involves at least one manic and one depressive. So it's really the difference of the manic and the hypomanic. Okay, let's do another question, and then I'm going to talk about the differences between manic and hypomanic. In the chat, can anyone tell me the difference between manic and hypomanic? Mm-hmm. We just said bipolar 1 is more severe because it involves a manic episode. And so it is, yes, perfect. It's more severe. Same symptomology, but it's going to be more severe. We talked about risky behavior, so that's going to look more harmful, right? So in hypomanic, you can still be compulsive, but it's not going to be detrimental to you. In a hypomanic episode, the person is still functioning, still going to work. It's not impacting their social relationships. Another big difference, there's not a requirement for hospitalization. There are no psychotic symptoms when it comes to hypomanic. Okay? So hypomanic is less severe. It is less days required for hypomanic. And there is no impact on functioning. Like, you know how normally in order to be diagnosed with something, it almost has to impact your functioning. There are a few disorders where that is not the case. It still is notable, right? We still can diagnose them with hypomanic, but in terms of the comparison to manic, it's just not as severe of a mood. So it's still elevated. You still have irritable. It lasts at least 4 consecutive days, whereas manic lasts longer. Like I said, all of the symptomology is the same. Decreased need for sleep, inflated self-esteem, impulsivity, but we're not having that significant impairment. No psychosis, no need for hospitalization. Those are really the key factors here. So when it says denies hallucinations or delusions, there's no psychotic symptoms, right? She doesn't feel distressed because it's not impairing her functioning. Okay, let's do this next one. What do we think for this one? Yeah, I see we were looking at manic versus psychotic disorder. What is psychotic disorder? Yes, 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 yes. So, loss of touch to reality, psychotic disorder is schizophrenia. Yeah. So, although we like to lump them all together, really, um, manic, hypomanic, they are moods. Okay. Whereas a psychotic disorder is going to be more about those things that we see in schizophrenia, like delusions, hallucinations, disorganized thinking, or speech. Sometimes there's abnormal motor behaviors, diminished emotional expression. So those are the things that are going to be psychotic versus a mood disorder, which is what we're looking at here. So I think that um, we definitely have we see some delusions, we see some things happening, but it wouldn't account for the elevated mood. That's what and the impulsive behaviors, right? That impulsivity and that elevated mood mixed with those psychotic symptoms is going to be a manic episode versus psychotic disorder. So the answer is B, manic episode. And then I just give you some slides about bipolar one, two. We went over those. Made sure to include slides about manic episode, hypomanic, which we just went over. Um, any questions about that? Okay, go ahead. You can ask your question.
You mean text or just
You can ask it. You
hey?
can unmute. Mhm.
Well, unfortunately, I was a little distracted and I didn't even do the like method, but I just glanced. So that's why I know I got it wrong. And I just relied on the last one we did. Well, actually, the last two, I didn't really, I was moving too fast. And I basically just went on some of the information that I do know, and it caused me to get it wrong. And so that's on me, really. But I do appreciate you breaking it down and just saying to focus on the mood. Because when I saw that he was speaking to the stop sign, the street signs, and like receiving messages, and I'm like, well, oh, I just had a negative thought that he crazy. But it had me definitely thinking, oh, he's having a psychotic moment because he's being delusional and hallucinating. So I initially went for, okay, this is a psychotic break. So, but that's really on me.
Yeah, thank you. Thank you so much for sharing. Um, could it also be manic disorder with psychotic features? So, mania in its definition includes the psychotic features. The difference is that we have the impulsivity with the $15,000 spending lots of money. So, anytime you see, so let me just give you what mania looks like on the exam. Okay. Rapid speech. This is typically how they're gonna, this is textbook like mania on the exam. Rapid speech, spending lots of money. Those are the main two. So if you see either of those, you should automatically be like, is this manic? Spends lots of money, rapid speech. The other added pieces was just that it is elevated. It also, you can also tell that it's different. I wanted to really show the differences between hypomanic and manic with these two questions. And so the last question, we saw that there was no hospitalization, there was no impairment of functioning, whereas this one we see with this client, there is a lot of that, right? Um, so you see those symptomologies. So I would just make sure you can go over both the symptoms, and I will also, when I send out the follow-up email, um, create a question that would be psychotic disorder so that you can see the difference between all three. Because schizophrenia is like its own, to be honest, it's its own category. So it's not even in your depressive, your bipolar, like it's not even in those categories. It really is, it's separate categories. So being able to understand what schizophrenia looks like and what those main features are is going to be also important. Okay, let's do 8. Okay. So for this one, it says the most likely diagnosis is we have mention of an event, moving to a new city for a job. So that's important. Reports feeling overwhelmed, Experiencing frequent crying spells, difficulty concentrating at work. You see how all of these can be very similar, but what is going to be your distinguishing factor is your time frame. Your time frame and the mention of an event. And so this adjustment disorder, which most people got it right. Adjustment disorder falls into that category of having a stressor event, right? And so the event is going to be particularly important. And you see, like I said, the other symptoms can overlap with other disorders. But what was really important was the time frame. Definitely wouldn't be persistent depressive disorder. That's way longer than 2 months. And then we didn't have enough criteria for major depressive disorder, although some similar ones. Yeah, persistent is 2 years in adults and 1 year in children. And it's not going to meet the criteria for major depressive. So it's like a less severe depression, but it's long term. It's like a long term, less severe depression. So with adjustment disorder, um, what it says is that you want to make sure that it's within, I think it's down here that it says 3 months. Uh, Yeah, so it's 3 months within the stressor event. Because if it goes past 3 months, it's probably something else, right? If these symptoms continue, for example, like 6 months, maybe it could be anxiety or whatever, or we would look at something different. But we're saying that the symptoms are coming from the stressor. And so that's why it's adjustment disorder. You might be thinking of acute. Acute is going to be where it is that shorter period of time. So PTSD is going to be that longer period of time. I think PTSD is like 6 months, whereas acute stress disorder is same symptom as PTSD, but it's going to be that shorter time frame. So that might be what you're thinking of when you think, yeah, when you think of the 30 days. Yeah. I know it's hard to keep it clear because it's so many time frames and so many different disorders. So sometimes it does. That's why I do recommend studying in categories. It helps you to also understand the differences in the same category. Um, and it also helps you to distinguish how it's different from other categories of disorders. So that helped to be honest, that helps me keep it a little bit straighter. Does adjustment disorder symptom of erratic behavior such as stalking people? For example, a client move into a new city with many changes and start showing odd behavior. Uh Not normally. Not normally. It's normally not odd behavior. It's normally the adjustment typically is um more of a I wouldn't yeah, I definitely wouldn't say odd behavior. If you're getting to odd behavior, then you might be getting into some of our ones that we just talked about, like the psychotic stuff happening and not adjustment. Adjustment is more like you're really emotional or you're really having a hard time with this change. Yeah, no problem. Savvy Social Work does a great job breaking down the differences with visuals. Great. Yeah, she's on my list of people to definitely check out. Oh, and I break it down right here. See, look at that. Major depressive will be considered if the symptoms were more severe, pervasive, and met specific criteria, including the presence of major depressive episode lasting at least 2 weeks. Anxiety disorder, we kind of ruled that out because that didn't meet the time frame and it didn't have anything about anxiety in there. And then we talked about PDD, about the timing. Okay, let's do 9. So we were looking at ODD and conduct. So tell me the differences between those two. What are the differences? You can put in the chat. What are the differences between oppositional defiant disorder and conduct disorder? Main differences. Perfect. Yeah, conduct disorder is going to be associated with like illegal things, like theft, fire setting. I am breaking laws, right? Oppositional defiant disorder is not really, yep, it's not really aggressive. It's not really, um, it's more about authority. Um, Age could be a factor. Age could be a factor too. But it's really about, they're both child disorders, but it's really about that authority part with ODD. So the answer is D, because we really are looking at the refuses to follow any directions. Um, and also this is another key factor, the argumentative at home, but at the school, no behavior problems, right? So typically with ODD, it is going to be one's normally it presents at home, but maybe not in school. Yeah. ODD has symptoms like argumentative, vindictive, whereas conduct is more severe, such as legal problems. Yeah. It's no violation of like laws. Like think I like what you said about antisocial. So in order to be diagnosed with antisocial, you would have needed to have a conduct disorder as a child, right? Be diagnosed with conduct disorder because their symptoms are very similar. You think about harming animals, right? Um, you think about theft, fire setting, um, could be some violence in there. All of this is for conduct, much more severe. Whereas oppositional defiant disorder is like irritating. Like you're irritating me. They're very irritable. They are having grossly disproportionate responses to things, throwing maybe big tantrums for things that are not um like it doesn't match. Yeah, power struggle. Yeah. So because we don't see anything like criminal in here, that's why it's not um conduct. Can oppositional defiant disorder be diagnosed as an adult? I don't know. That's a good question. I know it's definitely a child onset. Um, yeah, we're gonna have to look that up. I'm gonna say no, but I don't want to necessarily say no because there are other like typical child diagnoses that can be diagnosed later, like have a later onset. I'm thinking of like we think about ADHD as like a child one, but it can also be found in adults. Um, no, ODD does not lead to antisocial personality. That's conduct. Why is the behavior at home and not at school also? No, that's just I don't know. I'm not sure. I'm not sure if the as you do your psychotherapy, you might find some reasoning for it. But that's just how it presents. That and it doesn't mean that it doesn't you just most likely will find that this argumentative and this authority issue sometimes is with the parents versus at school is more structured, um and maybe they don't have that issue at school, but at home they're having a lot of issues with following rules and things like that. And then conduct is let me see. Oh, A and B are more likely to affect all settings. um so just something to look out for. Yeah, minimal behavior at school. Yeah. Okay, ODD can develop to conduct if not treated. Could be. Yeah, could be. But it's definitely different. Definitely different. Okay. So we're at 9:03. I want to be cognizant of the time. I have 22 questions, so we can definitely keep going. Um, but I just wanted to be cognizant of the time. I also am going to be doing a special for those that have dropped in for today and aren't joining us for the rest of our series. We have two more classes coming up for the next two Tuesdays. Next week is macro. And then the week after that, which is November 4th, we're going to be doing just all practice questions. And so I'll send out information about a discount on just those two classes, if you have not already joined us for the rest of the classes. But we're going to keep going. So let me change it on here. Okay, let's do number 10. I wanted to make sure with this one you saw the difference. So this one's conduct, right? So you see the difference in behaviors. Um, Still see something about authority figures in there, but it's has gone to a different level, right? When we talk about breaking laws. And then I just have some slides about both of these. Okay, let's do 11. Yes, I feel like everyone was on the same page with this one. We got 100%? Yes, autism spectrum disorder. You see that the hallmark features are going to be delayed and repetitive speech, limited eye contact, rigid adherence to routines, and difficulty with social interaction. These symptoms are more consistent with autism spectrum disorder than with social anxiety, which involves fear of social judgment. So we didn't really see that. And then ADHD, which typically involves hyperactivity, impulsivity, and inattention rather than social withdrawal and restrictive interests. So good job. Let's do the next one. Okay. So when we have schizophrenia with mood episodes, that equals schizoaffective. So schizoaffective involves psychotic symptoms like hallucinations that occur independently of mood episodes, in addition to the presence of mood symptoms during other periods. So it's not a mood disorder with psychotic. You already have schizophrenia, so you know that. But now, separate of that, you have some episodes of depression as well. So it's almost like they're periodically happening. And so that's schizoaffective. So it led with schizophrenia. That's why it's schizoaffective. Okay, let's do a personality disorder. Okay, let's see what we got. We were a little all over the place. It's okay. We might need to just brush up on our personality disorders. So it says that we have um intense relationships, feels empty when not receiving attention, constantly seeking reassurance. So feels empty when not receiving attention. I know intense relationships can be pretty much all of them, but this one is going to fit more for histrionic, right? Drama, drama, drama. Okay, let's see about the next one. Okay. It looks like we were between borderline and dependent. This one was borderline. The client symptoms, unstable relationships, intense emotions, Fear of abandonment and chronic feelings of emptiness are characteristics of borderline. Dependent is a pervasive need to be taken care of and difficulty making decisions independently. So you see how you really, when you're looking at your personality disorders, you want to know what that key feature is so that you can distinguish between them. If you don't hear me saying anything else, that's what I want you to hear is that you want to make sure you know what the main thing is. Like they're going to have overlapping symptoms because with personality disorders, it's going to affect your social relationships. That's why it's a personality disorder. So it just looks different in how it affects it, right? Our other scenario, it affected it because you just were always trying to seek attention. This one is affecting it because we have these high kind of intense feelings, unstable relationships, intense emotions, and fear of abandonment. So all that together. But I would say looking at that unstable relationship, typically with borderline, you're going to also see sometimes it'll talk about cutting with borderline too. Like self-harming will also typically go with it. And then I gave you some slides on personality disorders. You'll see it's very short. That's all you need, something short. You don't want nothing long. And I also gave you a video in your email of ways to associate it with different like celebrities to help you understand. Yeah, fear of abandonment for borderline. I'm used to reading about them threatening others or manipulating them. Yeah, that intense emotion. Yeah, for sure. Okay, 15. Oh, this is a good one. 15. Poor Tom. Poor Tom. We that term peeping Tom. Poor Tom. He's not gonna get away from that. Yes, voyeuristic. I wanted to highlight that again, you may not see this on your exam at all. But this was one of my hot topics, the paraphilic or sexual disorders. Wanted to make sure to highlight some of those just because there's something that I feel like I know I didn't really I don't think I studied them when I was looking for studying my exam. Um, but you may see them on the exam, so I just want to make sure that we go over them. There are some more. of the paraphilic disorders, but these wanted to highlight some of these. Um, A is what you saw in the scenario. Exhibitionistic is involving exposing one's genitals to unsuspecting strangers. And then C is involving touching or rubbing against a non-consenting person. Okay, 16. Okay. Perfect. Insomnia. Also wanted to highlight that sleep-wake disorders could be on the exam. So A involves sudden, uncontrollable episodes of sleep, narcolepsy, insomnia. I feel like we all are familiar with that because we might suffer from it. And then the circadian rhythm sleep-wake disorder is when you mismatch between the body's internal clock and external environment, like a night shift work, and that wasn't evident in this scenario. So common things, I feel like sleep disorders we're kind of familiar with, but just wanted to make sure you had a good grasp that you might be asked about them on the exam. I don't know. I wish I could tell you what exactly would be on your exam, so I don't know. Okay. I hit the wrong button. Hold on. Hold on 1 second. I was doing so good tonight. Okay, back on track. All right. Perfect. Substance withdrawal. Just wanted to draw the attention that substance use terms and also medications could also be on your exam. I feel like substance use is one of those areas that we forget um, as well. This one was really about the severity, right? What is the severity? How do we determine severity when it comes to substance use disorders? And these severity um, ranges are going to be for all substance use disorders. So you would just fill in a different substance, but the criteria and also the severity is going to be very much the same. So the answer is moderate. It's characterized by the presence of 4 to 5 symptoms. And so our symptoms were using more of the substance than intended, unsuccessful efforts to cut down, spending a lot of time obtaining or using the substance, experiencing cravings, and continued use despite negative consequences. And so that is the moderate level. But I also put the criteria of a substance use disorder, okay? And then I put the different levels. So 4 to 5 is moderate, and then 6 or more would be severe. In order to have a substance use disorder, it has to be at least two. So 2 would be mild, and then it goes up from there. And we'll do one more. All right, the answer is ana abuse. If you remember, we talked about this when we talked about aversion. Ana abuse and aversion go together. B and C are used to treat opioid use. So Suboxone and Narcan are for opioids. And then naltrexone is for alcohol, but it doesn't create an adverse effect that was described in the scenario. So there's a few more questions after this one. We got through a majority of them. How do you feel? Do you feel like there are certain areas where you want to brush up for diagnosis and medication? It is a lot of material, but overall, I would not spend um an exorbitant amount of time. The generic mids, yeah. Sometimes you can find I feel like sometimes you can find a commonality like Lamb and Pam, but to be honest, it's more just about looking at them. I do have them listed in the PowerPoint a little bit later, and I would also do it by category. Um, yeah, personality disorders, yeah. It's just a lot of information. But I wouldn't spend a whole lot of time on it. Um, Weeks is fine. I definitely wouldn't spend months on it because of the proportionality of how many of these questions will be on there. I also wanted to ask those that will be that have been with me for the past couple of weeks or past it's been since September, right? Yeah. Um, did you like this format better versus the lecture, more heavy on the lecture and then questions? Or did you like just going straight into the questions and a shorter time frame? This one? Okay. Okay, good to know. Good to know. What area will you say is the area to spend the most time? I would say focus on the hot topics. It's a good place to start. Oh, good. Yes, the macro questions are hard. Yeah. So what I'll do is you'll still get all the slides for the macro, but make sure that I am beefing up the questions so we can focus more on the questions and then similar format of questions and information, questions, information versus all informations and then the questions. So I'll try to adapt it for next week so we can have a more digestible and more productive session. But thank you all for joining me. I hope you join me next week. Yeah, shorter lecture. Okay. Yep, I will see you next week. This week, I want you to study the diagnoses that we went over. So review your diagnoses, review your medication, and also review anything that we've gone over so far that you feel like you need some more time studying in. Um, because again, diagnosis is important, but if there are other things that you still are working to study, then you want to work those in this week too. And I'll see you next Tuesday too. Next week, we're back at 7. Okay, we're back at 7. So I'll see you at 7. I'm gonna reduce our lecture time a little bit, beef up our questions some more, so we can get a lot of questions. It's going to be easy because we have research, we have supervision we're going to talk about, we have group practice and community and policy. So we have a lot of we have a lot of areas that we can target, and it's great because you're going to get questions that aren't direct practice. on any of the exams. And so definitely don't want to miss next week. So I'll see you next week, 7 o'clock. Um, and I can't wait. If you have any questions, feel free to reach out to me. I will be sending out an email with the recording, but it will also be on YouTube. It'll be a public video, so it'll be on YouTube as well. Have a great night, and I will see you next week.